This works.
I mean, like that phrase because it's like implying that you're only half a person.
But
You're like I'm my own.
awesome. Who all gets here?
I guess by seat, I mean you could say practices that are happening out in the clinical environment that may have benefited the patient, should they possibly have been available. So the idea is to combine what you're doing in the field, connecting what's happening in the academic world, the best practices or cutting edge medicine, and keep everyone on the cutting edge of what's happening. Because for those that have taken paramedic a while ago, the continuing education process, you get intervals of things, but to be able to sit there and have that academic back and forth discussion. A great example of that is for those that may not have attended before, the point counterpoint that they do down in Baltimore. You have active discussions about the clinical care of the patient. So as we look at our EMS system here in Harford County, continue to find ways to grow and develop and support that continuous quality improvement process. This is a key element in being able to have those discussions and grow together as clinicians and as a system. So thank you for taking the time to attend both in person as well as online. I see we have quite a few people online this evening, so welcome. Those that are in person, make sure that you've acquired a handout packet here. As we go through later in the presentation, there'll be some EKGs that we'll review and talk about. This packet lets you see them right in front of you, so you can measure and count and draw and scribble and take notes. There you go. So our first case presentation we will take a look at was a case that was managed by Brendan Hero. Brendan, oh, there you are. So, all right, I'll get started. There you go. Passed off to Charlie.
All right, guys. Hopefully everyone online can hear us okay. For everybody in the room, in order for them to hear anything in front of you, if you can use your table mics, if you don't know how to use it already, because you guys haven't screwed with them enough, just hit the little button just so that it's right on the front edge of the thing so the light turns on. I'm assuming that everybody online can hear us okay. This is meant to be a discussion. If you guys have questions, comments, anything like that, please feel free to raise your hand in there, or if you want to go ahead and write in the chat, just hit the chat button on there when you get a chance. Yeah.
Anyone that's in person here, just a quick housekeeping item. Does anyone mind if their photograph is taken? Our agency photographer is here. All right. Thank you.
Ray, if you could just hit the chat button on there. Yeah, anybody online, if you guys have any questions or don't want to like actually speak out loud, just hit the chat button and we'll get you taken care of. Cool. So let me tell you guys a little bit about the first call here. So in March of 2026, Medic 55 was dispatched for a call. It was reported for breathing problems. The caller advised that their cousin was having a pretty bad asthma attack. The patient was grabbing at the collar and was looking pale, but was breathing. Minutes later, oops, went too far. Minutes later, the call started to take a turn. There was heard screaming in the background on the phone. When they asked if he was breathing, the call taker said barely. The caller became uncontrollable, was not willing to start compressions. The phone just kept on getting passed around a few times, with one lady stating that this is a really bad asthma attack, and the other person was just screaming into the phone. Comments were made to the call taker, such as, "He's gone." While 55 was en route, dispatch advised that the call is being upgraded to a cardiac arrest. Additional units were added and were en route from Aberdeen, from the hospital, including a nearby tan pants wearing paramedic. On arrival, the crew encountered a tight bedroom, very little space. The crew members crammed down the tight hallway, and it was at the top of a very narrow staircase. Patients found in cardiac arrest with a nebulizer mask. So, of course, CPR was initiated immediately, and once where did you guys find the patient? Patient was on the bed and it was impossible for them to do CPR there. So they moved the patient to the floor. And while like a well choreographed dance, extra help came in. Not that you don't get enough extra help in Havity Grace, but everybody was there. An IO got started and asystole was confirmed. They started epi, intubation was completed, and I'm pretty sure you guys had a student at the time, right? Someone was riding as a student. After 3 rounds of epi, patient got a great perfusing rhythm. So walk me through what you guys' thoughts were after you had your ROSC. What was running through your mind there? Because this didn't seem like just a standard cardiac arrest.
Not sensitive. So we knew the patient had a history of asthma, and that's why he presumably died. After we fixed, his heart problem, we did get to the underlying cause before he potentially rearrested. So we decided to treat the underlying asthma. Consulted for orders for bags, nebulizer treatments, dexamethasone, mag drip, things of that sort.
Okay. The initial pulse ox on the report was showing that the reading was, after resuscitation efforts, the pulse ox was 75%, but the end tidal was 99. For the BLS providers in the room, your normal end tidal is going to be between 35 and 45. So having it at 99, if I'm not mistaken, our monitors actually max out at 99. So that said, what that means is our patient is holding in a lot of CO2. How many times have you guys actually seen a cardiac arrest where their end tidal is high? Normally we expect it to be extremely low. So what were the meds that you started in the house?
We started off with the mag drip at first.
Okay.
We wanted to do the nebulizer treatment and stuff, but we didn't have the T-piece adapter or the adapter in the bag. So we just did the high concentration oxygen and the mag drip while we were moving them out of the house.
So for the out of county people that are online there, one of the issues that we have with running a inline nebulizer is that we can't quite get, the hospital was supplying us with nebulizers that have little holes on the top. And one of the problems we recognized pretty early on here at the training division was if you try to put positive pressure using that, the air goes right out through the nebulizer. So here at DES, we were supplying very specific nebulizers that had it was the standard old-fashioned T-piece with the corrugated tubing. We had just started getting them, we had just started putting them into the field and tried to start getting them off the trucks. But I imagine that's probably what you had, just what you had gotten supplied. Mm-hmm. So, there's nothing. Remember that the point of these situations are not to point out the flaws and things that went wrong. It's actually, we're looking at where we can make system improvements from these and what could be improved. So since I was there, I wasn't there to correct anything. What I was looking at was what of this situation can we improve for the next time? So the only medication you were able to actually get in on scene was MAG. There was a lot going on. How many people did we cram in that room?
I think there was 4 or 5 of us.
I think so. And this was
like 10 people down the hallway.
There was a tiny bedroom. When I got there, I had to squeeze up the staircase and around the corner, and they had literally an entire row of Havity Grace volunteers ready to go, which is great. I mean, we love having the extra help. There was a firefighter on. Do you remember who it was that was on the bag valve mouse? Was a firefighter or a DES person?
Both. As Brian reminded.
They were there as a firefighter at the time.
Yeah, he was there.
So we started MAG. It was kind of nice because we had the second paramedic. We just passed the radio out the door. Said, "Here's what we got. We're busy." So the second paramedic was actually able to start that consult for us. So in order to do an inline neb, we need to have that T-piece, and we need to have this little adapter that goes on the end so it can connect into an ET tube. That was another thing that was right in process during this time when we were trying to get it started. So we got duo nebs and dexamethasone, I believe, en route.
Yeah.
Okay, so what about the bags? What all bags did you take in with you? You remember?
Brought everything. Red bag, green bag, Lucas, suction, monitor.
Did you feel like you had everything that you needed? I guess that's the better question.
For the actual cardiac arrest, yes.
But then we started realizing that this was no longer a cardiac arrest. This was the underlying rhythm problem, or the underlying problem for this was it's actually an asthma exacerbation here. So we could have probably gotten all this stuff done out in the ambulance, but we have to remember during a cardiac arrest, we still have to extricate the patient, especially on a narrow staircase. So I had never even thought, wow, we should start MAG this early on. So that was a pretty cool thing to see. It wouldn't have even crossed my mind. If you have been following our previous videos, our previous training videos, we have videos on CPAP and BiPAP where we actually are talking about capnography and what this means for patients respirating. If you're having a high capnography, it's great in a cardiac arrest because it tells us that the patient is actually creating respiration at the cellular level. And this is promising, especially for trying to get a patient back. I mean, this was an asystole patient. I don't remember how long we ran this. How long do you think we ran the actual arrest?
If my memory serves correct, I think we had ROSC within like 12, 13 minutes.
Yeah,
of the confirm arrest time.
So they were already en route when the patient arrested, assuming that the call taker, witnessed this correctly. Do you guys think that the primary goal here is to deal with the fact that the end tidal is so high, or that the oxygenation is not as great? What is your guys' thoughts? Because they're both problems: stupid high end tidal and your oxygenation. What do you guys prioritize? Anyone? You expose oxygenation. It's not an easy answer because it feels like both of these numbers are flashing at us and we're not really sure which to do. So I learned a few things from this. One of the things that I learned from the intensivist when I followed up on this case, they sometimes will get patients with a capnography 130, 140, like well above what our monitors will read. They're unconscious and intubated, but they prioritize oxygenation. So we definitely need to not focus so much on that carbon dioxide, which that was a learning point for me. I definitely saw that 99 and thought, oh my gosh, we need to breathe faster for this patient in order to try to blow off that CO2. Again, in order to increase your pulse ox, your oxygenation, it's not necessarily breathing faster that's going to fix this. It's increasing that functional residual capacity, which means to add PEEP or to add FiO2. That means fraction of inspired oxygen. So that is making sure it's connected to an oxygen source. You guys checked it while you were in the house. But what about going down the stairs? I mean, at some point, we had to disconnect the patient. How do you guys get a patient out of the house when they're on the top floor on a narrow staircase? What does the ventilation situation look like there?
Getting any ventilation happening. Something that narrow, which I've been in those places. It's just get them down as quickly as you can and start bagging them again.
So what if you guys didn't hear? He said you're lucky to have them get any ventilation at all because we're just going to scoop them up and try to get them down as quick as we can. The problem here is this patient is having a severe asthma issue now. So we can't afford to not be oxygenating this patient. In order to deal with the end tidal being so high, we did adjust the rate. We started to breathe a little faster for them. I dare say hyperventilate, but we were definitely breathing faster for them to try to blow off the CO2. Now, one thing that we noticed is the manometer. When we had this patient, our biggest issue was the manometers that we had just put on our bag valve masks. They actually were starting to redline. One of the things when we use a PEEP valve on these new bag valve masks we have is it does increase that initial volume that's in their lungs. So when you make that next breath, you may not be able to get in as much volume. Again, volume is not what's going to fix the oxygenation. So the key here, the front edge. Yeah,
Can I ask a quick, did you have a PEEP valve on this case?
we did have a PEEP valve on this one.
Intro arrest or just post arrest?
Both.
Got it on.
Why?
So the big thing that, at least from my perspective, was to make sure that the lungs were oxygenating properly. Did you guys? I mean, you guys were bagging before I got there.
We didn't apply to PEEP valve until we got there.
Until I'd gotten there.
I would think that this is a cardiac arrest is a situation when you may not want to have a PEEP valve because of the hemodynamic consequences of PEEP. We consider 5 centimeters of water to be sort of neutral, so maybe that's okay, but anything more than that could be harmful to the hemodynamics. And in the ROSC asthma case, a PEEP of 0 is probably ideal. We call that ZEEP.
Zeep.
I didn't make that up.
You sure?
Yeah.
So what Dr. Swart is talking about there about the hemodynamic status, one thing we want to really consider when we are using PEEP is similar to when we are using CPAP. What people don't think about with CPAP is that it is pretty much acts as a cardiac machine, not just a respiratory device. So when you are inflating those lungs and they're taking up more space in the chest, they're squeezing in on the heart. Because it's squeezing in on the heart, it can't fully expand. It can't fully get in as much blood. It also squeezes on the inferior and superior vena cava, which decreases preload, which then lowers your blood pressure. So we do have to be careful, like you said, about adding too much PEEP. It is not uncommon for us to see people who are applying PEEP. They say, well, 5 is good, so 10 is double gooder, and that's not necessarily the case. But yeah, I think during that initial stage, we couldn't oxygenate any better. So we were just trying to figure out what our issue was. And again, we learned a lot from this call. In hindsight, I agree, probably not, maybe putting the PEEP valve on there right away was not the strongest move. But it was fresh in my mind. This is literally what we've been rolling out. So I thought, oh, this is a perfect time. I am pretty confident that I had it not above 5. That I would say for sure.
5 the whole time.
I think it was 5 throughout the whole transport. So with those manometers, why are we putting them on there? So we're measuring a pressure. Hopefully that pressure that we're reading at the manometer is similar to what's in the patient's chest. However, as we were talking earlier before this, that doesn't necessarily mean it's the same, especially when you have restriction in the airways. So this patient, severely restricted, and you're squeezing that bag valve mask to try to get air in to create a chest rise and fall. The issue also is that air needs to be able to escape on its own. So air stacking, you guys have heard that term, especially in paramedic school. We're trapping air in that chest without the ability for it to come back out. So as we're bagging, I look over and we notice that throughout this, many times in this, as we're squeezing, as you see on the picture there, it's starting to redline and it's starting to get well into those higher pressures. We really need to be careful about when we are using those pressures. We are to be using it for chest rise and fall. We want to be just enough that we are making the chest rise without over inflating that lung, especially the injured lung.
Was this patient intubated at this time?
He was intubated pretty quick, so I'm pretty sure he was.
I do remember though, during the initial time when we had the PEEP valve on, it kept on returning back to 0. And the PEEP returning back to 0 means that when you set it for 5 and you bag and you let go and they exhale, you should still see that reading at 5. But in this case, it kept going back to 0, which made me feel like we weren't actually getting a good seal with that mask.
So if it was a mask or if it was a eye gel, that high peak inspiratory pressure may cause that seal to fail. So this is a situation where they really need to be intubated to use that high pressure.
Yeah, especially if it gets around the ceiling, and then you start getting gastric inflation.
That could be why it goes back to zero, if you have an air leak.
Sure.
I was just curious while we're talking about the intubation process, is there any school of thought as to the size of tube that might benefit patients in this case? Because I remember when I was doing my clinicals in the ED, I had a RSI where the respiratory therapist asked me what size tube I want. I just said 7.5 because that was kind of the standard size I was thinking for this woman. And the doctor encouraged me to go up to an 8. And then after, when I asked him about it, he referenced, I think this more was probably in relation to vents more so than anything, but he referenced how sometimes our COPD asthma patients tend to do better on larger tubes as far as the ventilation and the amount of PEEP that's inside of them. It's obviously when we're working arrest, airway patency kind of comes first, but is there any school of thought to, hey, if I can maybe squeeze the 8 over the 7 in this person, should I probably go for the 8 in these situations?
Yes, as long as it fits in the airway safely.
Well, any other questions at all? All right, so at this point, and again, for you guys online, feel free just send a message in the chat, or you can just raise your hands through the app, and someone is actually there watching it. So at this point, we have to remember that it's not anybody's fault if they're doing something wrong. Sometimes we just need a little bit of help. So coaching is going to be really important here. And you can't take any offense to this. If somebody said, "Hey man, you need to slow it down just a little bit," don't take it offensively. Sometimes there are many times you have to put your ego aside here, because at first I'm like, oh, who the heck are you? I know what I'm doing. In reality, it's a high stress situation. Like we just have to put that aside. So yeah, definitely. Hey, buddy, compression's a little lower. You need to go a little faster. Some of the ways that you can do crew resource management here. For the most part, if I'm not mistaken, Brendan didn't really do many of the skills. For the most part, it seemed like he was just delegating, right? I'm pretty sure. I mean, I think I said, "What can I do to help?" And he said, "Get an IO," or "Somebody get an IO," or whatever it might have been. He had a student with him, so he delegated, obviously, why don't you get the airway done? Everybody had a job, and it was really nice to see. We've been getting a lot of emails where this may not necessarily be the case on every arrest. So maybe this is something that we can identify as a priority of ours. But definitely don't be afraid to open your mouth, regardless of which position you've taken. Hey, give a little bit of encouragement. So I remember saying to the provider that was on the bag valve mask a couple times, hey, we need to back off on the pressure that we're giving. Make sure that we're just getting a rise and fall, but try to keep that needle out of the red. He was doing a great job.
It sometimes has to be in the red.
Yeah, we
like, otherwise you're not going to get any volume in.
I think our concern was that it was like getting pretty high. And again, this would have been a great time for us to recognize, maybe take the PEEP valve off. Maybe that was more of the issue.
Yeah, we generally don't want it to be too high, right? This is the exception to that case.
Yeah.
You have to recognize that. Otherwise, you think you're doing something wrong.
So
when you have a bronchospasm that's severe, it requires more peak inspiratory pressure just to get the volume in. Otherwise, you're not going to get the volume in. You're going to be underventilating the patient severely. But the reason we care about the peak inspiratory pressure is because we care about the pressure in the lung in general, is that we don't want to distend the alveoli too much and cause barotrauma. And in this case, so the bronchospasm, think of it this way, is taking the brunt of the pressure, and the alveoli are not experiencing that pressure. So if you're using a mechanical ventilator, you measure a peak inspiratory pressure and you measure a plateau pressure, which is an inspiratory hold, and that allows the pressure to equalize. And it's in this case, it would have been probably normal, and with a high peak inspiratory pressure, and the plateau pressure being much below that, which is safe. You don't want the plateau pressure to be like over 30. on a mechanical ventilator. Centimeters
Centimeters
of
of water.
water.
Yep.
The unit. So the bronchospasm protects the alveoli. If you don't have bronchospasm, you have a big inspiratory pressure, then you're going to stretch the alveoli out and damage them. Mm-hmm. And this thing, this bag, it's supposed to be AI or something, right?
It is.
Yeah, that's a mechanical ventilator. Don't be confused about it. You just are driving it instead of gas or electricity or whatever.
Is there a question online?
Yeah, Harrison chimed in. He was on the scene and said everything went well. And what was seen was wondering if there's anything you would have done differently.
I'm sorry, can you repeat that last part? I apologize.
Just wondering, it thought everything went well from what they can see on the scene, and just wondered if there was anything they would have done that you all would have done differently.
So that's a real loaded question, because when we left, we thought that went great. We really thought everything went great. I mean, it was all timed well. Yeah, Harrison, he was a champ, because he was, if I'm not mistaken, he's who we sent the radio out to. There's that support role that there's just no way to cram another person in there. Unfortunately, in retrospect, we started to look back and say, gosh, maybe there are things that we could have done differently. And we didn't know what we didn't know. I have been in EMS for 20 years. I teach at the college. I do initial education, and not once have I ever seen anything talked about with this. It's like you had to see it. This is why we're doing what we're doing here, to try to pass on so that nobody else makes the same, I wouldn't say mistakes, but make some adjustments that would improve the patient. So considerations of removing the PEEP valve for these patients. That definitely was the first thing that we recognized. And we're going to get into some of the other things that kind of happened along the way as well. So up to this point, yeah, I think that what we wish we had differently was making sure that all of the equipment, especially the way that our airway bags are set up, we kind of started doing a reevaluation of what could our airway bags instead look like. What could be the lesson learned from that? We really started looking at our bag valve masks. Like Dr. Swartz said, this is you plus this bag creates a ventilator. It's a human-powered ventilator, assuming that you're doing it correctly. The ventilator, though, has a lot of functions. You control flow, which is how fast we're squeezing that bag. I wish that I could get everybody to squeeze the bag slowly instead of just squeezing it like it's a human-sized stress ball. So flow is one of the settings that we can set on a ventilator. We can set PEEP. We can set the peak pressures, but the peak pressures are measured inside the lung. We are only seeing what's coming out of the bag valve mask. So like Dr. Swart was saying, the way that I would imagine this is if you were trying to use a bag valve mask through a drinking straw, that pressure is going to be really high on the bag valve mask side for you to get a little bit of air out on the other side. We have no way of measuring it on the opposite side when the airway is that restricted. So we need to be using our best judgment to look for chest rise and fall.
We do. It's just that you need a mechanical ventilator to actually measure that.
Right.
With this setup, we can't.
Right. We don't have the ability with what we have currently, which is also a reason we're over here. We're looking at mechanical ventilators. We did just recently get the Vortran approved, the Vortran, which is a plastic disposable, but there's only so many things that can do, especially for $120. I mean, it's pretty awesome, but it wouldn't be the best for this case, especially since we don't have a good measurement system.
Question.
Yeah.
With regards to the PEEP, the ZEEP, the patient said that it would go down to 0. Could there be other things like differential diagnosis speaking? Like I'm trying to think of what can be causing this. If my patient is intubated, I got confirmed they're intubated, I see good chest rise and fall, could there be another clinical reason for it to go down to 0? Or would it 100% of the time mean that it's a leak?
We control PEEP, right? And so you either have a PEEP valve on and you titrate up the setting, or you don't. So I'm not
I mean, if you have, so let's say we're going for a PEEP of 5, and then it goes, we set it to 5, but it's zeroing, it's going to 0 anyway. We said earlier that would mean that there's a leak in the.
Oh, yes.
Yes.
So- So his earlier question was the patient intubated at this point? When we connected that bag valve mask to the intubated patient, it immediately went to 5.
Okay.
And it never went below 5, which let us know we didn't have a leak. This is yet another tool in our toolbox to consider if you are using PEEP in that cardiac arrest or in that intubated patient. This is how you know you're maintaining your seal. If not, definitely something to consider. A ventilator is going to recognize this right away, that it's not able to maintain that pressure, and it's going to advise that there's a leak. We don't have that with our bag valve mask. So this is a way for us to know, do you have air getting past the cuff?
You generally measure an inspiratory and an expiratory volume on a ventilator. And if there's a discrepancy, I mean, there's going to be a little bit of difference, but if there's a big discrepancy, then it suggests that there's a leak. So you put in 450 cc's inspiratory and you get out 250, or you lost 200 somewhere. And the eye gel, it's going to, if you have, in this case, when you have high peak inspiratory pressures, that's probably because you're unseating the eye gel. If it's a mask, then you probably have bad mask seal. It's hard. That's why an ET tube is desirable.
And correct me if I'm wrong, his face, if I'm not mistaken, he had like a really sunken cheeks.
He was very
Yeah,
thin.
he was very thin.
He's a very thin guy, but I remember it looked like the firefighter was struggling to get a good seal because the cheeks were kind of sunken. So definitely. En route, I did not travel with them, but en route, from the story that I got, things started getting a little harder to bag. What was your student telling you?
Pretty much said that, hey, I can't ventilate this guy anymore. So, like what we're taught in our programs, we, before we left, confirmed the tube with the video scope. It was placed good. He was already left side diminished. We're still getting a capno reading. So the only thing in the dope out acronym that we couldn't rule out was a potential pneumothorax. And with him having a potential probable asthmatic cause of arrest and us doing the CPR, my initial thought was to do decompressions. Yes.
What else can cause to have a lot of resistance to bagging?
The air stacking.
And what else? What's another thing? Like a mucus plug or a blood clot or something physically in the tube.
Yeah.
So, as far as I could tell, we were still getting stuff from the tube. I mean,
you can't tell. You're holding the bag there, and it's just the feel. Like you don't know if anything's in there or not.
And when I was talking to the student, I asked him from his perspective what he thought, and he said, we were aiming at the higher end of that yellow, and he was doing a pretty decent bagging, but then he noticed it just kept on getting smaller and smaller, and it was to the point where even if he squeezed a little bit, it would shoot from 5 straight up to 35, I think, and he just felt like he couldn't get any air past that point. Yeah.
We for students, the dose mnemonic, so could also have a tube displaced. You could have a right main stem. My thoughts on that is our students don't a lot of times use the stem. I witnessed that today when I was in paramedic class. Don't use it. Now I know it's tough to use the back of it. I get it. But there are other things like equipment failure, pulmonary, pneumothorax, like Brendan said, obstruction, displacement. Through the back of the ambulance, you're moving the patient around all the time. That tube could came out.
Absolutely.
You're biting on the tube.
And I believe I asked him. So the student he was pretty proud of it. I think he was pretty happy with his tube. He wanted to make sure that wasn't going anywhere. So the impression that I got from this was that we were still moving air. It just wasn't moving well. It was like a smaller volume, and it was almost as if it was getting tighter. Like he said, he verified to make sure the tube was still in place. Definitely we didn't go straight to needle decompression, but then it came to, all right, we got nothing else. So he opted to decompress this patient. After which, did you have improvement?
Significant.
Okay, significant improvement. Sounds right. Sounds good. Get to the hospital and caught a little bit of heat from the ER. What happened? What was the concern there?
So the physician was just confused as to why he was talking about a method where we would essentially disconnect the BVM and like manually squeeze his chest for about 20 or 30 seconds and to allow natural air release, and then pop the BVM on and keep ventilating.
So what problem does that solve?
The air stacking.
Yeah,
Or-
breath stacker. Yeah. Auto peep's another phrase for that.
Now let's be honest.
What's
In,
that? Just disconnecting the BVM and chest compression.
Yeah, you just kind of described what it was.
now let's
Sort of grab their chest and push on it, and you should hear gas coming out.
But to be honest, out of everybody that's in this room, show of hands, how many people had thought to do that? Would have thought to do that? So, thought to let's disconnect. Let's disconnect the bag valve mask and allow for them to have a full amount of time to exhale, or go as far as to say let's actually squeeze on the chest.
When the other move would be to drop a suction catheter, flexible suction catheter, make sure it's not an obstruction in the tube.
I mean,
those two things.
What's that? If you just hit your mics so the people on there can hear
I've
you.
encountered that not recently, but in the past where I've had that, and we've actually just spitballed it and came down and said, let's pass suction, make sure we don't have an obstruction. And just with that time frame, you get that, for lack of a better description, the off gassing, and it gets a reset.
Yeah.
Yeah, which made us think, at least made me think after this, as I was writing this up, is it possible that they said, we're not getting any good compliance, let's go ahead and decompress. So they pause. They literally disconnect the bag and they pause. They say, all right, let's go ahead and start the decompression. And again, it could have been that the time while they were doing the decompression was actually what was needed, maybe not the decompression itself. That was one of the initial thoughts, because at this point we didn't have any x-rays or anything to confirm. We're just going off of, it's hard to make that decision.
That came to one of the questions. Are there any vital signs that you have reported from when a patient started to deteriorate? How are they presenting? Were there vital signs that were showing that?
Do you know the answer to that?
So as far as I remember, we don't it's kind of happening in the moment. So what we could see on the monitor, everything was still what we had worked them up to.
Yeah, I don't think, looking over the report, I couldn't look at the signs and say, yep, here it is. This is when it happened. Just trying to put myself in those shoes, I would imagine I would have had an oh crap moment, and I would have probably reverted back to, all right, ABCs. And blood pressure probably wasn't the B in that. So I would have thought it would have been really hard for me to throw a book at him for saying, all right, you should have your set of vitals for this one. But I don't remember there being anything recorded that screamed there's a problem here.
Hey, are you guys able to hear me in the room or no?
I can hear you. Yep.
Hey, it's Moose. So I'm the one that asked that question, and I think you bring up some really important points here, right? So I think first what you guys were talking about with the physician at the emergency department asking, I guess criticizing why you guys decompressed. I also I get that stress of that acute moment of, oh crap, my patient is crashing. At least I'm assuming that they were crashing. I think the reason I'm asking if the vital signs were checked is because tension physiology has to be there for the decompression to occur, right? And part of tension physiology is the tachycardia, the hypotension, all these things. Not necessarily absent lung sounds, but reduced lung sounds. So that's the logic behind me asking that question. Certainly not criticizing the team, just trying to get some more information for all of us to learn.
Yeah, absolutely. No, it's a great question. I unfortunately I just I don't have anything there, and it was a little bit ago. That's a great question now to look back on.
He mentioned the lung, I did check the lung sounds and didn't hear anything. Now granted, we are moving down the road, so a little bit tough to hear, but he was completely absent from what I could interpret.
On both sides.
Yeah.
And he still had a pulse.
And it is important to remember with breath stacking, you are gonna potentially get less lung movement, right? Because think of a balloon getting overinflated, so that is not the best that's not the best tool to get your differential list down, right? That's why we try to look for that tension physiology in that. And again, I'm not trying to criticize here. It's a learning opportunity for all of us. Thank you for presenting the case. I had one more question, but I'm blanking on it. So when I remember, I'll ask again.
Yeah, by all means, jump in.
All
And Moose brings up a really good point. We're not here to pick on him. It actually takes quite a bit of bravery to agree to come to this. So let's first acknowledge that in the room here, because I know that he's going to stab me once we leave here. But no, this was an excellent case.
If you get stabbed in the chest, and we know what to do.
He'll stab me somehow, I'm sure, whether I needed it or not. Now the thing, I'm sure you would. The thing is that came from this, what you guys don't realize is we have so many of our initiatives from the county here that started actually because of this call. We have the bag valve masks that we have. We actually we're looking into better ways for needle decompression to make sure that we have the proper sites. Did you use our card? Yeah. So let me tell you about this card. If you guys are not from Hartford County, there's a certain somebody in the room who might have given us a card before I was hired here. I was at the college, and Dr. Chismar back here gave me one of these SAM thorasites. And I thought it was kind of silly at first, and then I found out how often people were putting an incorrect needle placement. All it is just a little yellow card, and it sits up underneath the armpit, and it gives you, it offloads the thinking. So if you have an extra fluffy patient, or they just have difficult anatomy, or it's low light, you pull the card out, no questions, right? That go nice and easy. But after that, and we had conversation about it, we also were looking at other forms of devices in order for us to confirm where we are. We don't have them. And we were looking into, and a couple of providers had actually reached out to us and said, hey, there's a device called a capnospot. It's a little device that has a colorimetric paper in it. So presumably, if you were to get in there, let's be honest, anyone actually ever hear the really loud rush of air that we're told from the book? I'm getting a lot of shaking no heads. Yeah, I don't think I have ever heard the rush of air, especially in a moving ambulance while we're freaking out. So when you put that needle into the chest and it turns yellow from carbon dioxide escaping from the chest, that would probably be a really nice feeling to feel justified. So there's a lot of these things that are coming from these calls. This is why we really encourage you guys to talk about them. You just hit your button.
Who's gonna get one?
There you go.
There it is. Also, Charlie, we were teaching a simplistic method of doing that by squirting out a full saline syringe, attaching it to the catheter, and as you're advancing, pull, and if you get air bubbles, you're usually in a voided space, versus if you're up against tissue, you're not going to pull bubbles, you're just going to pull. It's really stupid to use, but I've done it several times that way with doing a needle thoracotomy or whatever you want to call it, and it works great. So, but I like the litmus paper one better.
it's
That's cool.
the best part is you can do both. You can actually do both. You can connect a syringe. What he's talking about is for you BLS providers, when we want to, once we poke the needle into the skin, presumably you could not pull on that syringe. And once you get through the wall of the chest and into that negative space, you start pulling on the syringe and it starts giving you air bubbles. You can actually connect it on the other end of that thoracic or on the cabinet spot and do both. So it's nice to have those extra measures. But we also started looking into this term I had never heard before of that was really pushed of lung protective measures. So that's when we start realizing, wow, we're picking up other things, because I went to go talk to the intensivist. This patient did make it to the ER and then spent a couple days up in the ICU. Once they were in the ICU, I went up to go check on them and talk with the doc. Let me advance my slide. And this is when we started talking about this. What would make the difference in our bagging? We talked a lot about the PEEP valve, but what can we do to make sure that you guys are all trained on what the PEEP is about, when to use it properly, et cetera? What do we do to make sure that we're not going into the bad areas of too much pressure? For the general cardiac arrest, one thing we considered was to put this, what if we got a bag valve mask that had a pop-off valve, just like on the pediatric, the neonate mask, bag valve mask that popped off at 60 centimeters of water. That way, it's just impossible for you to give too much. That would be convenient. If you did, for some reason, have those rare cases where you did need to give those high pressures, you could just disable it. Turns out, when I've started pulling some stats, we really can't determine what 6 seconds is. We're supposed to be doing this once every 6 seconds. Every single cardiac arrest that I've pulled, there has been, at some point, hyperventilation going on. So on this one, you pull the little paper off and it will give you a light that actually blinks every 6 seconds. Like, we can't, I'm trying to make things, it's not to make it easier. It's not to make it dummy proof. It's not to do any of those things. And it's definitely not to insult anyone's intelligence. But I always call it the Charlie 3 a.m. approach. I only have so much mental energy that I can devote to this. What do I have to do to remove the thinking? If I can have note cards, checklists, if I can have devices that will kind of automate some things for me, these are the things we want to consider. We also have newer medics. This is a pretty young department as far as the age of, experience age. You guys are going to make mistakes. It's going to happen.
Charlie, can we go back to the decompression for a second?
Yep.
Like we're moving on.
Yep. Sorry about that.
Is it plausible that this patient had bilateral pneumothoraces and needed rapid needle decompression?
Yeah. So,
absolutely, right?
Yeah, absolutely. And the first question was, well, hold on a second. What could have caused it? And the easy answer is, what if it was the bag valve mask? It's really easy, especially if he's not in the room. It's really easy to attack the guy that's not here. Well, it was probably the bag valve mask because we saw it going into the red. But now we've all just learned here, maybe you do need those higher pressures in order to have the low pressure get through to the lungs. So maybe it's not him. Or maybe it's because we have a full chest full of air and I'm mashing on the guy's chest. That probably is not going to be helpful, especially if he's not exhaling very well.
What was the respiratory rate prior to that?
Prior to
having difficulty with the bag compliance?
We kept them in the 20s. We were, again, focused on the end tidal at the time.
What's the consequence of having a high end tidal on this guy?
We didn't know. The truth is, having a high end tidal on an unconscious.
You mentioned it earlier. You said if 120, CO2 level, then they're usually unconscious or very altered. So they also get hypotensive. They become less reactive to the vasculature, to like their own epinephrine or any epinephrine we're giving them. So there are consequences to it. Yeah. But you often tolerate some. This is 120, even 90 is pretty high, but you often tolerate like 70 or 80 CO2 level, just like the permissive hypercapnia, similar to the trauma concept of permissive hypotension.
Yeah, Dr. Schwartz, would that also manifest itself in an increased ICP?
It could. It's gonna give you vasodilation, right?
Yeah.
And if we want this guy who just arrested to have some good blood flow, it might even be beneficial. 120 is too much, but to some degree.
It all falls into the neurological outcome of the patient, which is high CO2 in the brain. You may not get a good neurological outcome.
And
So
see,
those are things you have to think about post-arrest, post-ICU, that kind of stuff.
and I'll speak for Brendan. We've had a lot of conversations about this, and again, I've been involved in this for quite a while, and this is all new. This was all new territory, stuff that I had never actually put thought into. What are the consequences of this patient being at 99? I don't think I've ever had a cardiac arrest with a patient at 99. I also didn't know a monitor would error at 99. That was a news to me. I didn't know that. So like the gut instinct is we need to fix it. And that was my gut instinct on scene when I first showed up. I said, holy crap. I don't know what you know what? This is easy. We can fix this. He's oxygenating well, more volume, more air in and out, lower the CO2. That was the initial thought. But while that would have worked on almost every other cardiac arrest or every other ROS patient, this one was complicated by the fact that he was in arrest because he was having an asthma attack, which then wasn't. It didn't really help our situation. So this was definitely something to think about. And again, I don't care if you guys can fault me, but I don't have anything to prove at this point. But nobody was at fault here because this was all completely new information that we now learned after the fact, like weeks after we were finding this stuff out. And that's, again, one of the great parts about bringing these cases forward. So moral of story, what ended up happening with this patient? So we pulled some of the data on him, and we found out, well, how did he turn out? Do you know about a lot about this? I'll pull the.
Yeah, he did not survive.
So
what is this picture of?
Thoughts?
Chest X-ray, right? Would you see anything abnormal on it? Or what do you see? Maybe. What's going on the left side down in the corner there? Looks very translucent, right? Right. So there's pneumothorax down there. What's going on the left side outside of the ribs? What's that translucent stuff that's outside of the ribs?
Subcutaneous emphysema.
Subcutaneous emphysema.
So
if you see the shoulder joint up in the far corner, if you come in like 45-degree angle towards the heart, there's a ribbon of more translucent X-ray that it's outside, just to the lateral to the ribs. That's air. Do you see any of that on the right side? Not really.
Which side did you say you had diminished on? Left side. So for those of you guys can't hear, he initially while driving, he's listening, using his stethoscope, says, I have diminished on the left side. Was he wrong? There was no way to know until we had a chest X-ray. And yes, it's unfortunate that he caught some flack for it in the end, but yes, this patient did have a left side pneumothorax. So
we don't know if they had it when they developed it, right?
Yeah, we have
absolutely no idea. I know that you had a lot of hard time bagging the patient, but if you got some movement, an ultrasound could have seen pleural sliding and proven that there was no pneumothorax, plausibly. This could have been from the asthma and the auto PEEP and or the CPR, or this could have been from the needle.
Or
we don't. Yeah. We will never know.
We'll never know. So the thing is, like, ultimately, I don't know. I call that a win because I like to believe it's probably because I was mashing on this guy's chest. But ultimately, if he doesn't hear anything or he's having a lot of diminished sound, he's having some issues, he then sticks a needle in and then he says, wow, I actually am showing improvement. That's the only thing we have to go off of. That's really it. So, you know, for what it's worth.
So Charlie,
Yeah.
he wouldn't have been wrong even taking slack from the ER doc, I shouldn't say slack, but taking that you should have done, like Dr. Short said, compress the chest, get all, he wouldn't be wrong with jumping right to a bilateral or unilateral needle decompression.
Well, again, now looking back.
Yeah, I mean, we can Monday night quarterback this all you want.
Of
Monday
course.
morning quarterback, or whatever you want to call it.
I'll be honest, I would have done the same thing. I would have done the same thing, or I might not have even found it. That's the worst part, right? I mean, he did an excellent job. He found it. They recognized that there was a problem. A student, nonetheless, was saying, "I'm having a problem with this," and they took an action. When I talked to the intensivists at the ICU, I asked those exact questions. What do we think could have been the cause? He says, "There's no way to know." Well, what do you think the right move would have been? He says, I don't think you made the wrong move, because all the time, that's what happens in medicine. We just have to do something. You have to make with the information that you have at that moment, with the knowledge that you possess at that moment, you have to just go with something. He said, we do it all the time. We put chest tubes in people all the time and find out later they didn't need it. So I said, do we think that he did something wrong? And he says, I think not. So it is. But I asked him that pointed question. I said, do we think the provider did something wrong? In the sense of we're trying to learn here. And he said, I can't say that I would have done anything different.
I have a proposed approach, which would be to, in this exact situation, to disconnect the BVM.
Yes.
Compress the chest, see what happens. If air comes out and air comes out and air comes out, that's great. If it doesn't, put a flexible suction catheter down there, make sure there's not a mucus plug. And if it goes all the way down and there's nothing there, then decompress the chest. This would be a ideal situation for a finger thoracostomy, because when you insert that needle and there's no pneumothorax, you are going to create a pneumothorax, right? If you insert your finger, you're not going to create, a pneumothorax in terms of lung injury. The needle goes into the pleura adherent, the needle goes through it, and then you have a defect in the pleura, and you have air leak and pneumothorax. You stick a finger in, you vent, and it's pneumothorax, you get the air out without damaging the lung. I know that that's not in the protocol.
Rob, can you do me a favor? Can you start typing that up? We need is Chismar on there? I don't know if he logged in or not. Just saying, if he did.
But it's the safe way to address this issue.
If you don't mind telling him when you get home, I'd appreciate that.
It's been proposed to the PRC. I know all this stuff, right? So, but I'm telling you that's the way. So I've done this on the same case in the ER, and where it was pneumothorax, and then I get air out usually because it's intentional pneumothorax, but it's not always. And if it's not, then it's safe. That's my point. The needle is not as safe.
Yeah.
When you're wrong. Right? If you have a total collapsed lung, you can stick a big needle in there. It doesn't matter as long as you're not in the liver or the spleen or whatever. That's a 2024 problem.
Right.
Seem to have fixed.
Yeah. No, the cards, please, guys, please make sure you carry your card. Bring the cards. We're stocking them. Just please come get them.
Right. So if there's a big pneumothorax and you put the needle in the right spot, then it's going to bend the chest and you win. But if you're wrong, then you've injured the lung.
Yeah, and like that's the thing. Brendan and I have walked away from this saying, well, we're not going to do that same way. Again, not admitting defeat, not saying that we're wrong, but now we're walking away from this, and hopefully all of you guys as well. And I'm hoping that you guys take this and spread that word. This is the disconnect between education and where we are in practice. We can't teach everything. It's not possible. And we should be constantly learning. Again, here I am thinking I'm at the end of my EMS career, and now I'm now today years old, finding out, oh, you know what? Simple test. Let's just disconnect the bag valve mask. guarantee you're not going to do it again, right? We're all going to learn from this, and this is what the goal is. This is what we're trying to take out of this.
So what's different on this X-ray, which is missing half of the apices? What do you guys see? So along the left side of the X-ray, there's more subcutaneous emphysema further down. This thing that's coming in, we see where it says X-ray chest / abdomen at the very top. It's cut off. You see the thing that comes down and curls into a little curlicue. That's a pigtail chest tube. So much of that pneumothorax is evacuated. And what do you see on the right side, lateral to the ribs? So more subcutaneous emphysema. So evidence of a pneumothorax on that side, although I can't honestly see the actual pneumothorax on this particular film. No.
Then,
All right, so this is a huge amount of subcutaneous emphysema across the entire chest, the shoulders, and the neck. And now there's a chest tube on the right side as well. And there's some cervical, go back for one sec, there's some up on at the very top on the cervical spine, there's had some sort of prior surgery. So the X-ray looking picture is a scout film for the CT, and then the CT scrolling back and forth over here. So on our left is the patient's right side, and our right is the patient's left side, and then the anterior is up high and the posterior is down low. And you can see the lung. There's still residual pneumothorax on both sides and a lot of subcutaneous emphysema.
So
You see the ET tube still in place there, of course.
trying to see, I just got a message actually from another provider who was at the ER. Trying to see, I'm trying to read it really fast. So it looks like one of our providers was actually there as a student, as a paramedic student in the ER. Their note that she documented was, Rosk achieved 9 minutes, continued ventilate BVM. On arrival, patient was GCS of 3, remained intubated, skin slightly jaundiced. Patient was hypertensive initially in the 160s. Hypercapnic in the 90s. EKG showed a sinus tach, severe crepitus bilaterally after placement of chest tubes while transferring to the ICU. Post bilateral chest tube placement, the BP was 119/59. End tidal was brought down to 40, heart rate 82, and at 100% while intubated. Bilateral chest tubes placed by the doctor with improvement in the blood pressure and the ET CO2 from the 90s down to 30. Continuous ventilation respiratory therapy. LR was initiated, ketamine drip, stat chest x-ray to confirm the chest tube placement. NG tube was placed, Foley catheter, transported to CT for the second chest exam. Thank you for sending that. I appreciate it. It's nice when we get messages. Yeah, so what was interesting, was unfortunate for this patient is that they did expire. As I understand, they had continuous seizure activity that was most likely from hypoxic brain injury. Remember that even though it was very quickly seen to go, the patient was quickly seen to go down, and compressions were started pretty quickly. They were profoundly hypoxic to begin with before they went into arrest. So it was my understanding that the patient's family chose to terminate further resuscitative measures. I think this was like 4 days into the ICU.
Yeah, that's correct.
So, any other questions about this? No? Awesome. I appreciate it. Want to move into just another little bit of information. So when we are talking about bagging somebody too fast and hyperventilating, what do you guys imagine just in a cardiac arrest type? We're talking about minus this patient. Just in general, if I went over and kicked Rob in the shin, I would expect him to be mad at me. but also I would expect that his leg would start to swell. And what do you guys do for swelling? Put ice on it. We put ice on it because we expect that that's going to reduce the blood vessels, and it's going to remove some of that out. All of the things that make you swell are going to stop being able to get to the site, and for the most part, reduce volume. Now, in a head-injured patient, if you had a head-injured patient, we talk about Cushing's as signs of herniation. We talk about that because if you had signs of herniation, remember we're talking about end tidal capnography again. Normal, by the way, is 35 to 45. If you have a head-injured patient, we really want to start targeting 35 on the lower end. But more importantly, what do we need to do if that patient is starting to herniate? We need to do something to try to reduce the vessels. So if we were to, I hate to say hyperventilate, but if we were to reduce the CO2 down to 30, it would start vasoconstriction in the brain, which would then remove the volume in the brain and then give a little bit extra room for that swelling to happen. It's a very temporary, but it's a temporary fix for our patients. So knowing that, what do you think is going to happen when Rob and I are on a bag valve mask on a cardiac arrest and we're squeezing the heck out of this bag? What do you think is going to happen during the arrest when we are hyperventilating our cardiac arrest patient? You're going to create hypocapnia. They probably are hypocapnic to begin with. We're only getting about 10 to 15% movement of blood through that patient to begin with, right? So I understand that we are told we need to ventilate once every 6 seconds, but we need to also consider that that's a guideline. We have the tools. I think that we are smart enough that we can look at this and say, hey, maybe we need to ease up a little bit on bagging. Not just are we going too fast, but maybe we're lowering that CO2 a little too far. So some of the takeaways, the key takeaways here is, again, we're aiming for 35 on a head injured patient, but in a cardiac arrest situation, we really would like to have a higher one. Like we said about our earlier case study, having a higher end tidal probably was helpful because it vasodilates in the brain. So it actually was getting more blood flow to the brain.
I mean, it's probably too much. And
it's a lot.
There was a study looking at recently that was looking at slightly, I think it was like 50 for at least PCO. I remember it was end tidal or PCO2 from a blood gas, and it didn't show any difference.
Yeah, I mean, yeah. I was going to say it's all theory at this point.
Well, no,
but this is good.
They were a randomized study in the last 2 years that it was thought. Yes, it is the exact same thought, but it didn't seem to be proved.
But we definitely agree that if you were to make a patient hypocapnic, probably not good.
Plus the hemodynamics
of it. So I really want you guys to take away from this case study these thoughts. We really need to be better on bag valve mask use. These are the key takeaways from this whole situation so far. We want to make sure that we are better on the bag valve mask. Who's usually on the bag valve mask? I hate to call the firefighter out, but it's usually the person who's least trained. Not saying it's the firefighter, just saying it's usually the least trained person. But respiratory would really like us to consider that this is really important. This is a really important task to be just giving away. So we really need to consider, like, hey, if you're going to give it to the new guy, coach him a little bit. These are some new terms that we've not heard of. You guys may have heard of barotrauma, but never heard of volutrauma. And this is from excess volume. We really need to consider how much volume we're putting in. Patients used to be a 12-12 rule. It was like 12 cc's per kilogram, 12 times a minute. And we realized that's a ton of volume. We've now since changed it to a 6-6 rule, which is 6 cc's per kilo, every 6 seconds. And, it's dramatically changed. So
I don't want to confuse anybody, but like this guy could take normal volumes.
Yes.
The 6, he could take like 8. maybe even a little more than that, but the 6 is for the injured lung from like ARDS, like multifocal pneumonia. Not all patients need that.
So any questions about this before we move on to the next one?
Yeah, I was just going to say that information like this, and you know, over the past year or two, we've been talking a lot about, you know, not over ventilating patients and things. And it's true, a lot of times it's firefighters or whatever that we stick on the bag because we're doing other stuff. But where we really could have impact with this is the CPR classes around the county, making sure that we're talking, because I do all the CPR instruction at Norrisville, and I have conversations with firefighters about this. So making sure this is getting done in the CPR classes and explained to them. Now they're obviously going to need to be retold this on the scene, but making sure that we're discussing this stuff in those CPR classes is where we could really have some impact for this.
Absolutely. Also in the debriefs after the cardiac arrest, what do we know? We just go back to the station and we just go on about our lives. Maybe take a second to say, hey, what could we have done differently? Now, and again, they're the new people, so we can't just immediately pick on them and say, hey man, let me talk to you about your bagging. We need to slow. It's not like punitive. We've all been there. So, but yeah, I appreciate it. Anyone else? Anything from online? Okay. Let's skip some slides here.
Okay, so we're going to move on to our second case here, which was a call that was handled by paramedic Tompkins. So initially, they had been dispatched for an 83-year-old male who was unresponsive. When they arrived, they found the patient alert and oriented ×2, appearing lethargic. The wife had introduced information that the patient had been discharged earlier in the day from Upper Chesapeake, with preparations being made to start hospice the following day. He was confirmed to be a full code with full medical management being desired. Anything you want to add in, Riley, from your initial impression when you got there?
My partner was familiar with the family, and so going into the call, there was like a pretty low acuity mindset. She said it was like normally like lift assist, just put them back in bed, and that kind of stuff. It's just like a non-serious mindset.
Being familiar, was your partner concerned at the presentation this specific time? Or?
She was not when we walked through the door. So this is not an uncommon presentation for this patient, and kind of like drove the initial contact family.
So next, you guys worked up your sample history. Past medical history included atrial fibrillation, dementia, some psych and behavioral, Alzheimer's, depression, hypertension, and cardiac. No known drug allergies, and a decent list of medications there. So the crew initiated their initial assessment. So our skin was pale, cool, and diaphoretic. Lungs were clear and equal bilaterally. Respirations at a rate of 16, 96% room air sat. Blood pressure 80/40, heart rate of 40. Then they proceeded to put the patient on a monitor and recognized a flutter. For those that are here in person, the packets that we handed out. So here are the EKGs they completed throughout the call. So you have those to look at. Everybody likes to enjoy and break down EKGs, right? I know there are a couple students in the room. So that was the initial 3 lead. Again, he was alert and oriented ×2 to person and event. Pupils were equal and reactive. So they started As they proceeded through their assessment, like normal teams do, they went ahead and initiated an IV at 20 gauge in the right forearm. And then as they were kind of going through this process, right, it seems like the wife approached the crew about, maybe we don't get too aggressive with treatment now, kind of taken back. Riley, you want to read a little bit more into that for us?
Yeah. So when we first got there, she told us that he was supposed to start hospice soon. So we tried to be as conservative as we could. He wasn't completely unconscious. He was just like incredibly lethargic. So then after, just talking to the wife about the options that we could go down, he had a full-on ankle episode, passed out, started drooling. It was just a decrease in LOC. So then the wife had to make a decision then as to like what her treatment options were. So then that's where we decided that the full medical management was the route we were going to go.
So that kind of conversation does bring into our normal segue in our thinking process, right? So, patient's unconscious. They're not quite on hospice yet, but obviously we recognize a change in expectation. But that also opens the door as things progress. Do we have, medical power of attorney, that type of information and discussion, right? As we think about the patient's individual rights and the opinion of those around them. Did you guys ever get to that part of the conversation with what was going on?
Yeah, we talked about medical power of attorney, that kind of stuff. The initial treatment was just going to be fluids because I think his most recent hospitalization had something to do with dehydration, and then that's why he kept on presenting this way.
So you guys had that conversation. The patient did have a status change, and you acquired your first 12 lead. So in your packet there, the first 12 lead, I think it's on the bottom of the first page. So in your interpretation, we had what appeared to be a Brady ventricular rate with an atrial rate that was tachy. Your initial interpretation was a flutter with a variable conduction ratio. Once that was done, then the patient did have an acute change. They had a witness syncopal episode with a loss of distal pulses. And again, that's when they had the conversation with the wife as to, okay, well, we have an acute change now, what can we do? So the team decided to pursue transcutaneous pacing and a fluid bolus. So Riley, if you would walk us through your thought process.
So this wasn't my first time pacing, but in school and everything, we use synchronized cardioversion for our treatment for AFib and A-flutter. But most of the time, the ventricular rate is at an uncontrolled rate. But for this person, they were at a controlled rate. So I was thinking that I just needed to get more squeeze out of the heart rather than increase the rate of the atriums going as fast as they were. And then them being hemodynamically unstable, I had to go with electricity opposed to it would have just been an epi drip would have been the other treatment, but that would have affected the overall rate. So I wasn't confident with my treatments all the way through transport or just throughout the entire call. But I just ultimately decided to go with pacing. I think it was at a rate of 80. I don't think I ever got full capture. I got some capture for some of the call. And then I didn't have time. I didn't bring my NARC box in with me. So unfortunately, I couldn't pre-medicate this man. I felt terrible about that. But yeah, so after a couple minutes of pacing, we were able to get, as soon as I saw his heart rate start to supersede the pacing rate, I discontinued pacing, and then his pressures became normotensive, and then throughout transport, hypertensive.
Doug, did you have anything you wanted to weigh in and thinking about the electrical therapies?
The ventricular rate is what matters. Sorry, the ventricular rate is what matters here. What's the rate that the atria are going? 300, right? Yeah, and that doesn't matter in the sense of the cardiac outputs from the ventricular rate. And so you're right. If they're critically unstable, then you start pacing them. If they're less so, then you can try something else like a medication like epi or atropine. Although atropine is less likely to work here. I think the goals of care is the real problem in this case. Is, the guy's supposed to imminently go into hospice care. Then I know that it's awkward. And all you have to do, the guy's unconscious. All I have to do is go by, paperwork and integrate what the spouse is saying. And they're not always thinking clearly in these situations. So cardioverting wouldn't have helped at all. Good, you didn't do that.
And one of the reasons that this was one of the cases we picked for grand rounds this evening was that discussion, right? Because as you said, in paramedic school, it's like, oh, AFib, A-flutter, here we go. I know what the treatment is. But you took the time to critically think about, what does this patient need? What do I need them to do better? And you chose the treatment path.
But so, yes, cardioversion, but only if it's a tachycardic rhythm. Yeah. And again, like the doc was saying, we don't care at that point what the rate of the atria are. We care about what the rate of the ventricles are. And if they're, and the rate I saw in here was 75, I think was the original rate. So, but I thought I saw something about something lower.
Originally on their initial vitals, it was 40. And then I think their second or third set of vitals, it was 75.
Right. So yeah, I mean, like Doc was saying, at that point, we don't care what the atria are doing, because ventricles that are going to be pushing the blood to the body. So
yeah. Yep. I just want to also point out, sometimes when it's 2-to-1 flutter, that it's a rate around 150 plus minus, and it can be hard to tell on the EKG tracing. And I've seen ER doctors give a couple liters of fluid for sinus tachycardia, but the heart rate didn't budge, and it's because it was flutter. It needed to be chemically or electrically cardioverted. Keep that in mind. That's not this case, but it's a fun thing for a flutter that I like. The best treatment for flutter is actually like an ablation. The mechanism is this electrical circuit going around the tricuspid valve, and you can get an electrophysiologist to ablate that away, then that often can fix the problem.
All right, so as Riley had mentioned, then as they continue to try to treat the patient with the pacing, they had some capture and it was less effective. And you'll see some of the translation in the EKGs there. There is one page where you can see we've got some capture in the process. Oh, they're on that back table there.
The other thing I was thinking about was what mode was the pacer on? So there's like a demand mode and a non-demand mode, and you can toggle back and forth. And so if the intrinsic rate goes above the pacing rate, it should automatically stop pacing. Yeah, the way I think about that is, if there's a demand, meaning if the heart rate's low, it'll pace. So if you put on non-demand, that's just sort of like, going to pace no matter what. And so we want to have it on the demand mode. And this matters for transfer of pacing at the hospital, because if the hospital pacer gets placed on the patient and they start pacing at, say, a rate of 90, when they get captured, then the rate's 90, and then our pacer should automatically stop. There was an incident a couple of months ago at Aberdeen where they told me that it was dual pacing, like both machines, the hospital and the EMS devices, the Zoll from the hospital and the Life Pack from EMS was double pacing, and I didn't understand. Somebody messed that up. Like somebody didn't have it on the right mode, clearly, and it took them forever to figure that out.
So the vital signs around that time, if you look in your packet, when we had that partial capture, blood pressure was 117/64. The rate was in its 70s. Pulse ox was 96%, respiration 16, and you guys started to capture CO2 So that reading was at 45.
Did he wake up?
When we first started pacing, yeah, he woke up.
He's like,
Because,
ow.
he was just having the full body convulsion, because I didn't have time to I didn't have my narcotics, so
Yeah.
he just started getting hit with, and I wasn't getting captured, so it went all the way up to 240, and then he was just eating it, until I gave him the ketamine and fentanyl. So, but then we moved him after he was medicated.
Did you arrive to the hospital still pacing him?
No. I probably paced him for 2 minutes, or 2 minutes into transport, and then that was it.
You didn't have an opportunity to transfer the pacing from EMS to the ED?
No. Not on this guy.
And it did look like I didn't make copies of all the EKGs because there were probably 12 captured by the monitor. So, but in there, you could see the trend of where the ventricular rate started to pick up and outpace the setting. So that takes us now, this is the hospital ECG, which is the last one in your packets. What they performed when they got there. So again, as you could see, we're still in flutter. It looks like a more stabilized flutter than before, where we had that variable conduction initially. Good, Paul.
Was there a calcium channel blocker ever used? Was diltiazem used or metoprolol?
Not during EMS contact.
No, I meant after the pacing and you disconnected the pace.
No,
Did you consider doing?
With the initial, the profound hypotension, I didn't want to.
Oh, he was hypo? I thought it was 117 over something.
When we started pacing, it was like 60s over 30s.
Oh, okay.
So then I didn't know how much compensatory mechanisms he had, so I wasn't going to hit him with that.
But again, the ventricular rate was not high. It was just the atrial rate.
What was the guy prescribed? What medications was he prescribed?
Was that question?
Try
Hey,
again,
it was
Moose.
me. Hey, what medications was the patient prescribed that he took at home?
This list is actually not that long. Not even one full page.
Donepezil, amphetamine, trazodone, amlodipine, atorvastatin, amantine,
You're good. You're good. Don't worry. You don't have to.
Xarelto.
I can see him. Yeah. And I'm assuming the calcium channel blocker wasn't new. Like none of those were new.
Yeah.
All right.
So yeah, as far as I knew, the discharge, there was nothing new in the discharge or recent change in history, as far as that went. I know you got to look at the chart, Doug. Is there anything in the findings from the hospital that?
I don't remember anything notable to add.
Yeah. All right. So, any closing questions or points of discussion in the room? You guys online? Good, Denny.
I was just kind of wondering, I felt like we kind of glossed over the epi drip thing, and I might have missed a detail, but why wasn't that? I'll ask you, Riley. What was your thought process again with the epi drip, and why the pacing route as opposed to the epi? Because I was a little confused. I thought that first EKG had a heart rate of 75, and I know your initial was 40, but I just recently had a case where I kind of had the same thing where my EKG was presenting a higher rhythm than like my pulse ox or my manual, or rate, I should say, than my pulse ox and manual. And then when I talked to the physician at the hospital, he said the difference might be more related to in my case, the heart not actually producing a palpable pulse like that far down.
Initial rate of 40s came from just like a manual. I just remember because my partner, she was driving conversation between us and the family. So while she was doing that, I just walked over to him and did like an initial assessment, and I was like, oh, he feels like pretty slow. But he had radial pulses, and then once he had the single episode and recycle the blood pressure. I just in medical school they just teach us unstable gets the table. So, and we didn't have an IV. I don't think we had an IV set up at the time. So it's just quicker just that way.
Okay, I was just curious. I thought I might have missed something in there, so thank you.
Well, you could, if you want to get the ventricular rate up, that could be helpful. I mean, I think pacing is truly the right move here.
I agree.
Yeah. So your flutter is going to have an atrial rate of around 300.
Right.
Like that's the way it is. So you want to have more conduct. You want to conduct more down the AV node, and that epi would be an option, but it's not the best option. We have like a sinus bradycardia, then atropine can be helpful, and certainly epinephrine can be helpful.
So it seems like pacing has come into more favor over the past couple of years because I remember not too long ago. Well, yeah, actually, it was a long time ago. But I remember earlier in my career a few times where I went straight to pacing and physicians like had a heart attack, like stop pacing and give atropine. And now we seem to be much more just go straight to pacing and skip the atropine. Is that kind of changed over the past few years?
Changed. I mean, there's always been the teaching of like the high grade heart block that it's not harmful, but it means you're not doing something else like pacing.
Right.
It just might not atripine's not likely to less likely to work in that context. So that hasn't changed.
Okay.
In like a long time.
Okay.
I mean, I was taught that in paramedic, school. I'm not going to tell you when I was in paramedic school. Probably around the same time you were.
I was going to say.
All right. Well, we're going to move into our third and final case here. Charlie's going to walk you through.
All right. So let me set the stage here. This is not a transport that we had, but arguably maybe it was one that we should have had. So pediatrics are definitely one of those things that we are concerned about, that we're actually pretty terrible about seeing. I know that you guys online may not be able to see this that well, but this is a I guess 5-year-old at that point. You can see here, this is May 14th, 2024. I don't know if you guys can see that, but this is at sleeping. This child here is really working pretty hard despite being sleeping. It looked really peaceful until you pulled up their shirt and realized, wow, they're sucking in pretty hard. This is the same child, May 7th, 2025. They do not have a history, any kind of asthma. They don't have a history of taking any medications on a regular basis. Pretty routine and healthy child. They were a preemie, which doesn't really have a whole lot to say into it, but they had something called bronchopulmonary dysplasia. If you think about, the best way I think I can describe it is, if you think about what it would be like if you're here at sea level and then you go up to the top of Mount Olympus, and imagine trying to breathe like that. It'll be a little bit difficult to breathe, but after weeks and weeks, your lungs would adjust to that situation. However, you're a preemie, you have underdeveloped lungs, and you get delivered and you're in the NICU on 100% oxygen. You're like that for a while. What do you think is going to happen to that physiology of that child when you decide, okay, time to go home and take you off the 100% FiO2, we're going to put you back to 21%.
So the body's already become accustomed to living at that level, so anything less than that is going to be hard.
Right. It's like, okay, we're going to take you from sea level, we're going to stick you on the top of Mount Olympus. So that's kind of that. But aside from that physiology, nothing else. This ended up the child in the ICU. This is down at University of Maryland in the PICU. You can see in the background there on the right side of this screen, that's called a vapotherm. Has anyone heard of this before? Vapotherm is basically it's a high flow nasal cannula. I know that it's out there as a optional supplemental protocol, but it is not something we can afford because it requires a lot of equipment, a ventilator, etc. Especially, let alone put this on every truck. That right there, you can't see it, but it is giving through that nasal cannula. That one is set right now at a 14 liters per minute at 35 FiO2, and the 36 is degrees. So it's actually warmed, has literally a warm vapor that's coming into it, which is pretty nice for most people. But what you don't see in the background is this child is breathing 40 times a minute. That the yellow at the very bottom, child's breathing 40 times a minute, tacking away at 120 for a heart rate. But luckily, in this picture at least, we're at 96%. We're only at 96% because of all of this oxygen. Now, I am not super familiar, I have to admit, I'm not super familiar with high flow nasal cannula, but my understanding is when you are blasting that much oxygen up the nose, you are removing the CO2 out of the dead space. And dead space for the BLS providers, the dead space is anywhere between the outside of your body and the actual alveoli in your lungs, which means all of the space in the back of your mouth, your neck, down your trachea, into the bronchioles. So that's all dead space that as you're taking breaths in and out, it'd be nice if we can exchange it with nice, fresh oxygen. That pretty much.
Yeah, you want CO2 out and oxygen in.
Yeah, so that's best understanding. Also, there's a banana in that for reference, with all good stuff. This is the same child, May 27th, 2026. If you see, this is a sleeping child. This is a sleeping 7-year-old, where you can see the retractions. I don't know if you guys can see that in the video online, but this is some retractions. Now, the concerning part here is most of the time when you look at this child, they're sleeping peacefully. There's nothing wrong with them. They have no complaints. Unfortunately, with this kid right now, the only thing that's wrong is a fever. The first time was RSV. The second time was rhinovirus. And now here we are. Child is having a fever at 102.7. After Tylenol, after Motrin, very difficult to keep it under control. So the parents, having already been nervous about the first 2 times of going through this, now sees this for the 3rd time. If you guys notice, this was all in May, 3 years consecutively in a row. Who knows? Maybe it's rhinovirus. Maybe it's RSV. Maybe it's flu. Maybe this kid licked a trash can at Dutch Wonderland. Who knows? But the truth is, it could be almost anything. Again, remember, this is not a kid with asthma. This is not a kid who takes medication on a regular basis, has been seen by pulmonology, and has had no reason to go to the doctor for anything else. So the patient eventually, after the parents are just driving themselves crazy, says, why don't we just take this kid to the emergency room? And because the finger pulse ox, by the way, is saying, it's saying 87 or 89 at room air. Again, I get it. It's a tiny finger, tiny human, adult-sized pulse ox. How accurate do we think it is? There's no, aside from the work of breathing that you see, patients breathing at like 45 times a minute. It's a little fast for a 6-year-old or for a 7-year-old. The next day, they see that the kid is still breathing at 45 times a minute. The fever is harder to control, and now they're sitting at 87. So what do? You call 911? You just pick the kid up, take him to the hospital? What would you guys do? Honestly, like, because we're stubborn, right? So the parents chose to just scoop them up, take them to the emergency room. Once they're in the emergency room, they realized, wow, Upper Chesapeake said, we're not able to take care of this kid anymore. Express Care came, shipped the child downtown. That's the emergency room down in University of Maryland. By this point, it's interesting because the child was actually doing really well on 2 liters of nasal cannula. 2 liters of nasal cannula brought the kid from 87 to 100%. Kid's asking questions. Why am I going to the emergency room? I feel fine. Why do you guys think that is? Thoughts? Kids are fine until they crash. They are fantastic and they will plateau forever, whereas an adult will just slowly start to taper off. We don't really talk a whole lot about that during EMT class. And we talk about it somewhat in paramedic school. So this is the same child right now that this knucklehead here is currently in the PICU over at University of Maryland. Despite all of the things that have been done, they are in the picture here in the center. The nasal cannula thing not tolerated well. Really is driving the kid crazy. Said, why don't we try maybe a simple face mask? At this point, they have received 30 milligrams of albuterol. They've received MAG. They got Decadron. They got, oh my gosh, there was, we don't know what's wrong with her because there's no need for, we're not sure what antibiotics to start, so let's just start them all anyway. Pretty sure there was Recefin. I'm not sure what all what was given. There was an antibiotic given during transport downtown. But ultimately, they were on this high flow nasal cannula for a long time. Now, the hospital loves this for peds. It does really wonderful things for peds, but there is no actual positive pressure being given, despite the fact that it is coming in at 15. There's got to be some. I mean, everybody believes there's a tiny bit, but it's not the same as like what we would consider for CPAP.
Gives like a peep at 2 or something.
Yeah, and intrinsically we're at 5 anyway.
But
2 additionally, right? So there is a little bit of recruitment here. This is the chest X-ray. There was a thought maybe there's a pneumonia forming, but I don't really see a whole lot. But this kid is still breathing. Temperature at some times was 45 times a minute. Was driving the kid crazy. So hey, maybe we can trial getting off that oxygen. You know, at some point you have to feed the kid, right? So I imagine that there was some sort of negotiation that happened, and she said, why don't we try to take off the mask long enough for her to eat? Let's see, I think I have an update there. Sorry, give me a second, I'm just catching up here. Got a 5-minute break from the mask for the respirations went from 35 to 62 times a minute. Pulse ox was from 97, 97 down to 91. Imagine that this child didn't go to the emergency room when they did. Imagine that that kid was at home up until it got bad enough that a person who was not a provider, who was not stressed about this, had finally said, it's time to go to the emergency room. They're in levels territory. What are you going to do? How are you going to treat this patient? You already know that they're going to require a ton of oxygen just to keep their vitals up. What are your options? Thoughts?
Not a breather.
Okay.
The closest thing we can get to that much flow of oxygen, as long as they're tolerating it.
Okay. I'm sorry?
The child's been followed at Hopkins or somewhere previously?
I mean, at some point, like when they were born, but they've been pretty healthy otherwise. In their history, this is the 3rd year in a row. In the history, they had seen pulmonology, on discharge, but ended up being cleared and didn't need anything lasting.
In between these 3 events, nothing, he's been normal tensive, breathing like a normal kid.
So we're seeing this a lot more. We're seeing this a lot more. The ER is full of these kids. They're full of these kids with rhinovirus, with RSV. We're in the season right now. What is that one called? It's called human, what was it? Metapneumo. I'm today years old hearing that word. Human metapneumo. Yeah, okay, I had no idea. Yeah. Go ahead and put your mic on. Sorry. They can't hear you online.
Back to your question about treatment, could you consider CPAP?
Good question.
Can you?
I would consider CPAP.
What does the protocol say?
You mean?
What do you guys think about the CPAP protocol? What is the age? The age is 13. So 13 and up, yeah, we have a pretty awesome CPAP device. Rob and I are pretty proud of this one. Not only is it a CPAP device, it's actually, we are approved to use it as a bi-level device. That's really awesome. How do you hook it on a kid? This is a kid who won't even tolerate a nasal cannula, let alone, can you imagine trying to strap this mask to their face? What are we gonna do?
There is a pediatric CPAP in the protocol, but it's for specialty, interfacility transfer only.
Yep, and it's been a uphill fight. So I had just went downtown to discuss this with Dr. Chismar, and we're going to try to see if we can champion bringing pediatric CPAP to the table. It's not uncommon to hear it done. They do it at Hopkins. Central Ohio is right now trying to lead the charge in getting CPAP all over the place. There's a paramedic in Central Ohio. He brought his daughter in with a very similar presentation, just like this. The problem is that kid was getting intubated. And right before intubation, he said, hold on a second. I know we can't do it in the field, but can we consider CPAP? And they said, honestly, at this point, what's the harm? Let's try it. We're about to our side of this kid. And the problem is the equipment. That's the biggest holdup. What is the equipment that we would have to have? We'd need a properly sized mask. And at the time, that hospital had one of these. This is a full face mask. It goes over top of the eyebrows and underneath the lips, right on top of the chin. Obviously, this is going to come in a couple different sizes, but what if this is the disconnect between us having pediatric CPAP and not? Conveniently, this is the standard 1522 adapter. So that means that we could take our existing stuff and plug it right to this, and it would work the same. What do you think the biggest concern is about putting CPAP on a child?
They're not going to want to do it.
They're not going to want to do it.
So in that instance, if we were to get pediatric CPAP and we needed to CPAP a child, but they're resistant, obviously in respiratory distress, you don't want to upset them. So then what do you do?
Good question. In my opinion, if they're resisting you, they don't feel bad enough yet.
I agree. I've sent several children of age like 3 and 4 down on non-invasive. I don't remember now if it was BiPAP or CPAP from Upper Chesapeake to PQ University. And they tolerated it because they were sick.
Yeah, there's a certain point where they'll just let you do whatever you want because they're just that sick. So we're hoping to get it before that point. We're hoping to be able to manage this patient. What is the closest appropriate facility for this child? Why not Upper Chesapeake?
First thing is, if I show up, they go, why is Aberdeen here?
That's just you though, Sam. I mean, Aberdeen might be the correct destination, right? Depending on the acuity of the kid.
Yeah,
Are they going to survive the ride to Bel Air or downtown to Baltimore?
If I thought this child was secure enough, I would consider feeding towards Hopkins for them, because that would be ultimately one of the better facilities. But if they're in, you know, this kid's looking like we're about to be circling, absolutely, you go to either Upper Chesapeake or Bel Air or
Yeah.
Aberdeen.
Do you have to consult?
Yeah.
Yes.
I might. I might.
I don't mean in general, I mean, do you have to consult? I'm just
Yes,
kidding.
I do.
Yeah.
Yeah, you have to consult. And then you've got the other thing, when you're up in Greg's neck of the woods, there's another whole problem there. And you may even want to be thinking about your travel times there. Do you look at aviation? So, it's the third option.
And that's a great thing to bring up. Is aviation the right answer? Have we considered that? I mean, we forget that we can use aviation for medical calls. And I don't know about you guys, but I've been noticing, and maybe it's because I have young children, I've been noticing there are less and less services available for pediatrics. Upper Chesapeake used to have an emergency room. They used to have a pediatric emergency room. The reason that this kid went to Upper Chesapeake was because online, on university's website, on Upper Chesapeake's website, it says they have a pediatrician, or they have a pediatric intensivist or hospitalist. There's a pediatric hospitalist on site 24/7, which is true.
It is true.
But they're in L&D. But they're available. And this is what I was hoping Dr. Swart can talk about, is what are the capabilities that we have available? I'm putting him in the hot seat. What are the capabilities that we have available at Upper Chesapeake?
So we have a pediatrician 24/7 that can do ED consults. I've called them, and they have admitted patients. If patient physically stays in the ED, and if it's obvious that it's not going to be a short stay, they transfer them, or they ask us to transfer them. But they are there. I've called them, and they've mostly not complained about it, and come down. And sometimes we discharge the patient, sometimes we transfer the patient. I don't remember recently having them observed under admission status in the ED in the last couple of months, but that is an option. Is it ideal? No, not at all. But it's not like there's nobody there. Is there a pediatrician at Aberdeen? There's an emergency physician, and then there's Dr. Lewis, the psychiatrist. And there's a hospitalist. It's usually a nurse practitioner. It's in the OBS unit. So we do not have that resource that limited resource at Aberdeen.
I think depending on the patient's presentation, it might be a good idea to do a dual consult between the two facilities. Ask the doctor.
Which two facilities?
I would consult probably between Hopkins and my local facility. More specifically Upper Chesapeake, since you have the pediatrician there. But to ask the question like, hey, I'm here. Should I come to you to adjust this now? Or are we just going to kick the can around down the road coming to you? Should I just head down to the pediatric facility now? Obviously, if they're unstable, closest facility, and do what we got to do to stabilize them. But if we got the time, I think most of us work 24-hour shifts. Like, you got the time, consult and take the trip down there if it ends up being better for the kid.
And you're actually supposed to consult with a pediatric base station, in which Hopkins is one, or at least, and Moose is still on the call, he can clarify this, but my understanding is that if you need true medical direction for a high acuity call, that you're required to consult with pediatric base station, which is DC Children's or Children's National Medical Center, which is not very useful to us, although you could get them on the radio, but Hopkins downtown campus, PGD.
Yeah, that's correct.
They're going to want the kid there, most likely. In my experience, they've generally said, like, bring them to me. But if they're not going to survive the ride, then you need to take them local if they're truly sick. And like, where are you supposed to take your pediatric ROSC cases? Hopkins, right? For us, Hopkins. If you're in Montgomery County, you might go to Children's National Medical Center, but those are the two. There's only two pediatric base stations.
Yeah, but how many of us, just when he asked that question, we're like, let's be honest. I'm not afraid to admit that I would have. What do I do now? We do have hand heavy. We do have our protocols. We do have all these things. But Brendan and I were just talking about this earlier. It is really important for us to recognize that consulting with a hospital is not an admission that you don't know what you're doing. They really do mean it when they say they're part of the care team. And it's not just, I'm asking for permission or I don't know what to do. A lot of times it really is just, hey, can we work together and come up with a solution? Is that fair? Is that a fair statement?
Yeah,
Because I grew up definitely in a time where you consulted, it's because you didn't have a choice and you forgot what your dose was or you forgot what to do there. You didn't know better. But they really do want you to consult, especially if you have the ability. You don't have to consult, but let them know what's going on and like have a conversation. Say, Doc, this is what I'm thinking. What do you think? So just putting it out there.
Charlie, if I can just add one thing to that, though,
Yes.
only because I'm dealing with a couple cases right now at work, and I imagine many folks in the room will empathize with this. There are times when paramedics are consulting, and the physician on the other line has no idea how to provide good medical direction. And what I'm running into as we speak is the documentation isn't there, right? So like if a physician straight up doesn't know the protocol or they provide inappropriate medical direction, that has to then be reported with whatever your department's reporting process is, like whether it's a special or whatever system you guys use. Um, because that's a problem. Like over the years, we've gotten used to physicians, like some physicians just providing crappy medical direction, not providing not advocating for patients during refusal, stuff like that. I just want to stress that has to be documented because yes, it should be a conversation between two colleagues, right? To try to get more information. It's no different if Dr. Swart is getting a cardiology consult on a patient or somebody else when he's working in the emergency department. But if the big thing that we run into as EMS clinicians is sometimes the physician on the other line does not know how to provide appropriate medical direction, and that needs to be documented every single time and sent up the chain of command. So that's just what I wanted to add.
You like it when they say follow your protocol?
Yeah.
Like, not helpful.
Yeah, no. Like, I mean, I'll give you guys an example. Like, well, this is recorded, right? I probably shouldn't. Never mind. We're good. I'm good. Thank you.
Absolutely. Yeah, I'm just going to New York. Yeah, that's it.
You're gonna go to Shrewsbury.
Not of a pediatric. I'm going to York. So this wasn't really meant to. This is just meant to. We kind of threw this case in last second, partly because it just happened last second. But it definitely brings the questions. What do we do? What should we do? We don't have the resources in our backyard anymore. What would you guys like to have? Is there something that you guys would like to be able to like, is pediatric CPAP something that you can see being useful? If so, send us some messages. See what, give us some examples of when this might have been useful in your guys' recent time. This is going to be the ammunition we would need in order to take it to the physicians up there. It's not up to Dr. Chismar. He's all for it, but it is actually up to the pediatric board who makes these decisions. So we have to be able to articulate the need.
They're amenable. I mean, they went for ketamine for refractory seizure.
Okay.
It took a little nudge, but not much.
And that's what I'm hoping. I'm hoping that's the case. So, yep.
Someone mentioned a peds ED. Probably not a bad idea if we don't have anything nearby.
It would be nice if we had a peds ED, but if I'm not mistaken, they just lose money. They just hemorrhage. Pediatrics divisions usually hemorrhage money, which is why it seems that we keep centralizing all the peds. They keep shutting them down and sending them downtown.
I mean, the hospital said, well, we only got like one peds patient here for the 48 hours, and we can't afford to staff as if we have 5 because we don't.
I mean, it's a good question. It doesn't become relevant until, it's your child. And then suddenly I'm like, oh crap, what do I do? What do I do when I need this? Is there any questions about this child? How is she doing? Hey, Karina, are you on the phone? Give her a second.
Yeah.
Take the high flight.
Hi, Karina.
Hi.
How you feeling?
Okay.
Are you wearing your mask still, or you have it in your nose?
I don't have it.
You don't have it.
Tell him you graduated, right?
I graduated.
Oh. Are you still in the PICU?
Yeah.
Yeah.
Are you going to be there for a little while?
Yes.
All right. When I'm done with all my friends here, I'm going to come check on you, okay?
Okay.
All right.
Say bye.
You want to say
Bye.
bye? Bye. Love you. Anyway, these cases that we have here, they hit a little closer to home. You know, this is my child, and this is right here in my backyard. These cases that we're bringing up here, we hopefully hope you guys get something out of this, because these are these are patients that are affecting you guys. And more importantly, we want to make sure that this is relevant to you. But we are trying to, here in the training division, we're trying to support you guys in making sure you have what you need. We just can't do it without you telling us. Luckily, this was a call I just happened to see, but I'm not there. I'm not out on the street, so I don't see all the things that are going on. So please let us know how we can support you, what you guys have going on. And keep in mind, if you guys have these cases, please send them our way and participate in our next grand rounds. Do we have an idea of what our next one might be? So end of July. If you guys appreciated this, please send us an email. Let us know what your thoughts are. If you want to guys see these things more often, please let us know. If you have some cases that you would like to pick apart, be brave. Send us an email. Let us know about them.
As you observe here, you don't have to do a lot of the talking.
Yeah, we'll take over for you. I promise.
We realize that some of us are a little timid, and that's okay. You know, Charlie and I, being educators, we're not so scared. But these are the conversations that we want to have, because this is how we learn, right? The interactive discussion. And I venture to say that everyone learned at least one new thing tonight. And that's the goal. That's how we grow as a system. That's how we get stronger. And our profession grows. You know, we talked about some ideas tonight with pediatric CPAP, trying to champion that. You know, no, we don't currently have the tool. Well, we have the tool, but we don't have the ability to. And trying to make that difference and make that case and advocate. The BiPAP, the bi-level ability that we have now that is entering the field for you to use for your patients. Again, that came back from patients that we observed that, hey, we can do better for these patients, and we can improve their outcomes and reduce their hospital stay and all of the things that come down the chain. So that's what's important, and that's how we continue to grow. We're going to put a slide up here for those that are online. There's a QR code scan. That's how you'll get credit for attendance tonight. For those that are here, at the back table, we'll have a QR code for you to scan. And make sure you guys get credit for tonight. We'll get that processed and up the MIMS and get your credit. And as soon as we get the July date booked, it'll be both on Facebook. It'll be sent through email for the Harford County volunteers. It'll be posted on the new DES training page on the volunteer SharePoint, as well as everyone that I have your email address for. If you register for tonight, I have your email address. You'll also be added to our mailing list to get information. We want to make sure that you hear about these opportunities and can attend and participate in everything that we offer. Right, have a good night. Thank you, everybody.
Of course I'm an idiot.
You know, I did the exact same thing.
Of course I'm an idiot.
My wife's a pediatrician. She was like, suck it out. I'm always like, rub some dirt on it.
Rub some dirt, yeah, absolutely. And Brendan, just so you know, Petrovic learned that you're his hero. All right, thank you all. And then for those of you guys online, we did record this, so we're going to try to see if we can figure out how to get it and be able to distribute for people who weren't able to be here. All right, thank you all.
a lot clearer than we thought. So you wouldn't really need
She had changed his meds.
But anything that needed to be like,
And
so like, even though I'm logged on back there, it's also on my phone.
finally made
Have you ever gotten a recording off of?
We saw her last week.
My
wanted to
Wi-Fi.
wait.
has-
What do we, 2 weeks?
It's probably
it's
too-
not
If I
that
press
hard.
N, will it be available for you?
Yes.
Yeah, you should be able to log back in.
Yeah, it'll cache it and save it.
CHF.
Feel free to ask, get any of my calls.